So, today we're going to talk about LDL. It's LDL and cardiovascular risk and plaque buildup as the bioindicator. I'll start with the main takeaway. LDL cholesterol is not the main cause of heart attacks and strokes, of heart disease. I know that's not what you're hearing everywhere else, but it's the truth. LDL cholesterol is not causing plaque in all people anyway. There's a group called lean mass hyperresponders. They have low triglycerides, high HDL, and some of them get very high LDL, as in 250, 272, 500. The new evidence is published now. In lean mass hyperresponders, LDL is just not building up more arterial plaque. Science influencers in the medical area, they're using a type of research called Mendelian randomization. And again, you'll hear it. I'm not telling you something. Most of you that are familiar with this have seen it. Started with Thomas Dayspring, Peter Attia, Tom Schneiderman, now Rhonda Patrick, several others are saying, and folks that I respect a whole lot, by the way, very, very good people, very good scientists, and very good educators. But they're saying they're using Mendelian randomization like a trump card. Well, the MR meaning Mendelian randomization, the MR studies show it, therefore it's real, and you can't argue with it. This sort of reminds me of the old story about the emperor and his new clothes. If you understand that analogy, you may begin to understand the connections here. The emperor and therefore most of his loyal subjects decided his new clothes looked really, really good, even though they couldn't see them and they couldn't understand where they were. It took somebody who was not that deep into this whole thing to say, hey, I don't see any clothes at all. Think Mendelian randomization. We will cover that. Adrian Soto-Mota, who's one of the three people that's joined us in this video, is a world-class epidemiologist and scientist in this space, and he gives you the lowdown on Mendelian randomization. We also have Dave Feldman, he's the fellow that came in from engineering, not medicine, to ask the question, hey, guys, I'm seeing all these people with very high, sky-high LDLs, but they seem to be healthy. They don't seem to be heading into cardiovascular disease. Could it be possible that LDL is not the case? Nick Norwitz, who's like Adrian, not only a PhD in human metabolism from Oxford, also at Harvard Medical School right now as a med student, and a very active YouTuber. He's joined us as well. So let's go back. Let's talk about some of the basics. Mendelian randomization does not prove LDL is the cause of heart attacks. The information is out there now. It's published. In this group of people, LDL is not causing increased plaque. Now, this is going to be a long show. Some of it can be significantly technical. So you may need to take more than 1 or 2 episodes to watch it. Maybe just plug it into your ears while you're driving or doing some gardening, except for the part where Jesus and the guys went a little bit deeper into the mitochondria. They gave you some good visuals to help understand it. Jesus, anything else I should share before we get started before we roll the tape?
I'm going to fact check you on that, Dr. Brewer. I'm sorry. We probably got confused. The mitochondria thing, we included that on our previous live that we had with Dr. Nick from Physiological. Okay. If you haven't watched that, that's really good. Mitochondrial health.
The other Nick. Okay.
The other Nick. Exactly. Oh, I see where the confusion arises. But so, yeah, go ahead.
So this one, they can just plug in and listen.
Just listen. This is a casual conversation between scientists, basically.
Correct. Very
I
good.
think that's how you need to see it. And just to rephrase what Dr. Brewer said, if you only want to take the main point of this conversation is LDL doesn't cause arterial plaque in all people. Now we finally have evidence from Dave, Nick, Adrian that say, hey, if you are a low carb or on a ketogenic diet, your triglycerides are low, your HDL is high, your LDL is high, maybe you are not in that population where you're going to be building more plaque. That's the evidence they found. And we have all the links on the description of the video. That's what this is all about. We can't say LDL doesn't matter because we believe it certainly does, but we use it more like a biomarker. We need more research. This is a first stepping stone on breaking that paradigm. That's it.
Well, before we go, I just have to remind you, you know, it was your role to keep us at 1 minute. And not only did you not keep us to 1 minute, it's at 6, and you caused a whole lot of it.
Oh man, you're always blaming that on the foreign doctor, right? Very good. Okay, well, so let's
hopefully you guys got this. As you can see, as Jesus said, it's a conversation between medical scientists, and we know that for some of our audience, it does get a little bit technical. But for a lot of our audience, a lot of folks are very interested in this level. So hang in there if you can.
Okay, well, let's not delay this any longer. Let's go to the video.
Thank you.
Setting of most.
They might not need much of an introduction. It's Dave Feldman, who's been on our channel 3 or 4 times now. The first time a couple of years ago when he was first starting this journey into investigating the group of people that he coined as lean mass hyperresponders. People who are metabolically healthy, but their LDL, quote, bad cholesterol, end quote, starts shooting way up. He's actually been able to bridge very well with the medical scientific community. A couple of folks that have been very active in that bridge are also with us. Nick Norwitz, PhD in Cambridge, right?
Oxford. I think I can. I'll give you that one. I think you were watching a video of mine this morning where I'm wearing a Cambridge sweatshirt. My brother's at Cambridge.
No,
so it's wear his swag more than me. So Oxford, we have a little rivalry.
No, I did that on purpose because of the rivalry. Adrian knows all about that. We love to call Harvard the Hopkins of the North. Speaking of Harvard, Nick is now at Harvard after getting a doctorate in Oxford in human metabolism or metabolic health. He's now, and I may have butchered that. You can clean that up a little bit later. He's now at Harvard as a medical student. But what he's really spending his time on is doing YouTubes. Very, very good YouTube channel, very active and very much in our space. A little bit geeky. So what I'll end up doing sometimes is watching Nick's channel, learning a lot from it, like I'm just doing right now on cholecystine and cholesterol and eggs, which we'll be publishing on a little bit later. And then providing that information to our community. We have Jesus here. Jesus and I keep talking about whether he's going to be giving me grief during this session or not. We'll see if he can resist. Then we have Adrian Soto-Mota. Adrian is a physician internist in Mexico, also a PhD from Oxford in human metabolism. Guys, I'm sure I oversimplified and didn't do any of you enough credit for your background. Other than, again, the thing that I really appreciate is providing this cutting edge science for us, especially those of us who care about cardiovascular disease, because I don't think you can get a more important topic right now. It's LDL. And is LDL really that bad? Is ApoB really that bad? There is a good bit of conflict going on right now, debate, and I'm excited to see what you guys have got. You've just created and published a whole new set of data which speaks exactly to this. Let me quit being an airbag and let you guys talk.
Yeah, as it happens, I actually have a little printout right next to me. I like touching the papers at times. So what you're speaking to is the match analysis, which we did in fact talk to you about before when it was preliminary and before it had gotten published. But as of a couple weeks ago, it's got its own DOI. It's now open access. So anybody watching this can literally go to the paper, download it themselves. If people had listened before or caught any of our presentations, Dr. Budoff was the first to present December 8th of last year. You may have even seen the graph that kind of made it famous, but there's a little bit more accessible graphs and what's called box plots.
Mhm.
And to the point you're bringing up, Ford, was specific to how much does LDL associate with atherosclerosis? And it's an interesting and important question to ask, but to be sure, and you'll hear the three of us push this quite a bit, is up until now, virtually all of our data that shows and examines this association are on populations that, especially if they have very high LDL, have some form of dysfunction in lipid metabolism, either partially or fully. Either the study is looking at those folks who have it. And the reason that's relevant is the things that help induce or at least associate strongly with atherosclerosis that can also affect your lipid panel and change these levels, like LDL. That's kind of important because that's literally the definition of a confounder. If one thing is affecting two things. And so if it's changing your lipid profile and also independently resulting in greater levels of atherosclerosis, then it'd be great if a natural experiment could appear, a population that seems otherwise metabolically healthy and doesn't, to the best of our knowledge, have some dysfunction in their lipid metabolism. And that's what we find we have in this population that we think. And this being the first published data, it does give us some comfort because it appears in a matched cohort with Miami Heart, who have otherwise average levels of LDL cholesterol. They do not have a statistically significant difference in atherosclerosis. That's the elevator pitch. Sorry if that was a couple paragraphs long, but hopefully that sets the table for us.
So can you or one of you repeat that in a sound bite? Because I think it's worth it.
You know what? I'll pass the ball to Nick on this one. Go ahead, Nick.
I would say lean mass hyperresponders, the phenotype we're studying, are an unprecedented group because they really uncouple high, very high LDL cholesterol, which is seen as the bad cholesterol, from metabolic dysfunction or underlying genetic defects in lipid metabolism, as in, say, familial hypercholesterolemia. So this is the first time ever in history we have human cases of extraordinarily high LDL with no metabolic dysfunction, no known defect in lipid metabolism genetically, and we get to really test rigorously the idea of, is very, very high LDL sufficient to drive atherosclerotic cardiovascular disease? And no matter who you talk to, no one can give a definitive answer on that question because we've never had a population like this to study. We now have a first glimpse into this population and the risk associated. And while these data are preliminary, I think I'm stealing this from Dave, they're preliminary but pivotal, because what we're finding is no evidence of increased coronary plaque on coronary CT angiography in these lean mass hyperresponders, despite the fact that they have extraordinarily high levels of LDL for a mean exposure of about 4.7 years. Now, we can pad that with caveats, but the fact of the matter is we are asking important, albeit provocative, questions and finally starting to get answers that are now spilling out into the literature. And it has created controversy. What I would say is, irrespective of who you are and what biases you might be bringing to the table, and we all do, try to really listen here and elsewhere to what we're saying and what we're not. Because something the three of us deal with all the time is people putting words in our mouth or misinterpreting what we're saying. So yeah, I guess that's my soundbite. It's a long soundbite. Adrian, you want to add?
A very long soundbite. Adrian, can you do any better than that?
I mean, I think that it's going to be repetitive with what Dave and Nick already said. However, we can say that for the very first time, we have data on people with very high LDL without other typical cardiovascular risk factors. And this allows us to see what's the isolated contribution of high LDL. And from this data, it doesn't seem like LDL is enough to explain the change in cardiovascular risk. That's
Can I-
goodness.
where I would stop to keep it soundbite.
I think I've got a soundbite for you. Up to this point in time, I think hardly anybody would argue, hardly, not everybody, but hardly anybody would argue that much of our assumption, LDL is bad for metabolically healthy individuals who have it at sky high levels, comes from a population that is not metabolically healthy and or has some dysfunction. It's extrapolated. And there are a number of people who I think it's fair would say, hey, don't extrapolate from our study that people who are metabolically healthy, who seem to have a functional lipid metabolism, should be extrapolated to those people who are not. And we would say that's fair, but it should be symmetrical, right? If you don't want us to extrapolate from our population, which we shouldn't, that it would apply to all other populations, again, I think it's fair. We should acknowledge that we just haven't done it up until this point, up until literally this study. And yes, I'm sure all of my friends here were all going to say exactly the same thing that Nick said. This is groundbreaking. It's pivotal. We think it's extremely strong. But at the same time, we will emphasize it's the first step in many steps to come. Is it a massive step? I think it is. It's something we've been waiting for. It's certainly something I've been waiting for 9 years since getting my initial lab report. And I'm excited for it to literally be talking to you now for the first time with it actually being in the literature. And I just have so much thanks to give, not just to everybody else, but for my two colleagues on this call. Like we've come so far. And I'm just filled with gratitude that we're finally here.
And I tell you what, again, it goes both ways because you've got folks over like Jesus and me seeing people with metabolic problems all day. And we've got tons of lean mass hyperresponders as well. And to us, the assumptions that the medical community continues to bring to the table, it just doesn't feel right. So we're very excited to have you guys doing the work you're doing and actually coming on the channel. Step aside and let you guys go ahead and present this the way you'd like.
Well, there's one question that I think we can all agree has been lingering this whole time, which is whether or not the lipid hypothesis can be taken as context independent. In other words, higher LDL is always worse than lower LDL. Full stop, regardless of the population. And I think to the extent to where there's that non-nuanced, just broadly based version, I think our data is very compelling to look at in that context, because I think we are bringing about at least the discussion that needs to happen on whether it is more nuanced than that. And I think that's if there's anything that I would hope we can all agree on at this point in time with these initial data, it's that simple recognition that it doesn't seem to be that context independent. And I think many low carb doctors have thought this for some time, but have wanted to see data like ours to know.
So why don't we spend a few minutes going over that actual data? Maybe you guys can present a couple of the graphs, and then maybe we can talk a little bit more about how the medical community is responding. Or again, if you'd like to take this another direction, feel free.
No, that's actually a good point, because for anybody who hasn't heard of the study before, and I'll concede my lighting is set up for it to aim at me and not necessarily for me to be able to read these, but I know a lot of these by heart. The Miami Heart study is actually headed up by Dr. Karam Nasir. He was doing the study and finishing it close to when ours was starting, the lean mass hyperresponder study, or as it's codenamed in this, the keto trial, as Dr. Budoff would refer to it. The keto group, our average LDL was around 272 milligrams per deciliter. And the Miami Heart group was an average of 123 milligrams per deciliter. Now, the Miami Heart group is not a true control in that it wasn't attached to the keto group. It is, like I mentioned, its own study. But what it was is a matched control, which is to say that the statistician on the Lundquist side was able to pull from the 2,400 participants that they have in Miami Heart a number of folks that actually were matched in age, in ethnicity, in risk factors extremely closely with the cohort that we were looking at that was within their age range. There were 80 of our 100 that were within their age range. And once matched, we're able to look at them, side by side. The things that I think are worth noting that are different beyond LDL is there's a little bit of a difference with HDL and triglycerides. The HDL of ours, I want to say, is in the 90s, whereas theirs were in the 60s. Those are still very high for both sides. Yeah. Ours was in the triglycerides were like in the 50s, I want to say, or 60s. And the Miami Heart side, I want to say, is in the 90s. Again, can't totally read this here. But the thing a lot of people zeroed in on was the BMI. The average BMI on our end was, I believe, 22.5, and theirs was 25.8. So some folks were saying, well, the Miami Heart group is a little more overweight. And granted, that's 25.8, which actually I think is below the average for US population. Regardless, fair enough. But the thing that we would push back on, at least with a lot of these initials, is does that actually equate to a massive change in cardiovascular risk such that being at levels of 272 milligrams per deciliter, which is in the top 10% of the top 1% of the population, is effectively negated if you believe in the lipid hypothesis as being context independent. Outside of that, the match is extremely close. So much so that I was dumbfounded when I got to see this for the first time last year. My gosh, now that I'm thinking about it, I think I was seeing this match analysis being presented from Dr. Budoff last year, this month, if I'm not mistaken, which is kind of crazy. That was that long ago. And it's taken this long for us to finally have it published. But yeah, that's kind of the quick overview.
I think that's right. I saw you actually came on and mentioned it on one of your videos, and I called you right after that, and you and I talked.
And it's hard for me to put into words what it's like to really invest, I guess, so much on something that 99% of the field that you're doing this in is certain you're wrong about when you don't even work in that field. So again, and I just have to really drive this home. I'm so thankful for folks like Nick and Adrian who've really put in an incredible amount of sweat equity to help us move this research forward, because there's just no way that I could have been doing this entirely on my own.
So Nick, Adrian, what are your thoughts?
I think one thing that we should struggle to emphasize is the importance of these data to everybody listening. It's a question I think we often each get. It's like, all right, well, what if I'm not a lean mass hyperresponder? Like, why should I care about these data? And I think at a high level, the phenomenology around this, like this phenotype, this lean mass hyperresponder phenotype, speaks to something, at least I think we think it speaks to something that is intrinsic to human physiology in all of us. And that the phenotype, the high LDL, high HDL, low triglyceride phenotype, which can be very extreme, with the LDL levels reaching, equivalent to a 1 in 1 million genetic condition, homozygous familial hypercholesterolemia. That phenotype is, an extreme manifestation of what's going on potentially in all humans with respect to physiology. And it's sometimes by studying the outliers and the extremes that we can get best insights into human metabolism and physiology at large. So there are kind of two arms of our investigation. One is the mechanistic and scientific, which is looking at, well, why does this phenotype occur? What are the driving mechanisms? We've talked to you about that before, the lipid energy model. So there's the academic mechanism, scientific, but then in parallel with that, albeit to some degree separate, or I like to try to keep the conversation separate, there's the clinical question of, well, what is the risk associated with this extreme phenotype? And as Dave said, at least the way it's talked about, LDL and ApoB are thought of as just high is bad, period. And you hear the term lower is better, on and on and on, and without much nuance or context. And to Dave's point, I don't even think it's controversial to say the risk associated with high LDL or ApoB is completely context dependent. One way to think about it, if you just want a visual or you're graphically minded, is like if you think of exposure to LDL or ApoB particles versus accumulation of coronary plaque, and you think about that on an X versus Y axis. So the further you are on the X axis, the more exposure to LDL you have, and then the higher up you are on the Y axis, the more plaque you have. Let's say that's a relationship. Let's say there's a positive slope for everybody. The degree of the positive slope, if it's super steep or super shallow, bordering on zero, is enormously consequential because you need to know what the absolute risk is in order to make, individual choices. So for those people who are lean mass hyperresponders and loving a ketogenic diet, either because they just love the lifestyle or because they're using it for a therapeutic indication, be it inflammatory bowel disease or epilepsy, it's relevant to know, are you going to develop rapid plaque in 4.7 years? Or in 4.7 years or in a decade, is there going to be a negligible increase? So it allows people to make informed individual decisions. So summarizing all I just said, the lean mass hyperresponder phenotype is an extreme manifestation of what I think is normal human physiology. Now we're tasked with figuring out, well, exactly what are the underlying driving mechanisms, testing our lipid energy model, and at the same time, in parallel, determining what is the risk of this phenotype and what are the implications of findings in lean mass hyperresponders with respect to coronary plaque or eventually potentially cardiovascular events on our understanding of the role of lipoproteins, LDL and ApoB, in cardiovascular disease.
And let me make an additional point there. Currently, in most people who access the healthcare system at any point, because they have abnormal, forget about lipids, they have a high cardiovascular risk. Lipids are a central part of the healthcare strategy. You could say that nowadays, the way we deal with increased cardiovascular risk is lipid-centric. And this has to do with many reasons, many different things. It has to do with the pharmacological success in getting tools to lower lipids. It has to do with the epidemiological studies, especially in the second half of the 20th century. It has to do with also our human nature. We are most likely to think in solutions we know than to think in solutions we don't have yet. And in summary, clinicians are trained and typically practice overemphasizing the contribution of lipids to cardiovascular disease. And there are counter arguments to this notion. I mean, there are several studies who have measured head-to-head which contributes the most to cardiovascular disease. However, because of modern nutritional epidemiology and the data we have available, it would seem as if, yes, the best thing you can do to lower someone's cardiovascular risk is to bring down their LDL. And these data really put into perspective if that lipid-centric approach is justified. And it's understandable why we got where we are, you know, like LDL, one of the problems is that, well, not of the problems, but one of the things that explain why we are here is that high LDL is a very frequent marker of insulin resistance. And it's a very frequent marker of insulin resistance because we have tools to measure LDL. It's a very frequent marker, you know, and because now because we have lipid-lowering drugs, because we have lots of insulin resistance, because it's more likely people will have a standard lipid panel than HOMA, you know, measured.
Yeah.
So it's really just and I mean to bring a relevant study that's not directly related with the lipid energy model. Very recently, we published data from Mexico's equivalent of NHANES, our national nutritional survey. The most frequent marker for insulin resistance was high LDL, for sure. Mm-hmm. So the thing here is that because now we have an example of high LDL without insulin resistance, we can ask a better question. And being, you know, playing devil's advocate and being cynical about it, well, yes, maybe I don't have the full triad. And we can, Dave knows that I want to test the cutoffs for the lipid triad as soon as possible. But, you know, okay, I don't fulfill the triad. Why should I care? Well, you should still care, because perhaps this data should make everyone question if we are really addressing the root cause of increased cardiovascular risk. It's just very rare to find an example with high LDL without the other cardiovascular risk factors. And this simply puts into perspective and should make us question why we do what we do. It's just easier for everyone to prescribe a pill than to teach someone how to implement lifestyle changes. And from the patient side, it's just easier to take a pill than to implement lifestyle changes. But if anything, these data, I hope, make people question, well, maybe I just can't get away with without lifestyle changes, right? The right way to address the root cause for high cardiovascular risk is through a different approach.
Can I actually capitalize on that real quick? Because honestly, this is a thing I do my best to not even be perceived as giving medical advice or anything like that, because I genuinely don't want people to make any personal individual decisions without working with their doctor. I will say the one concern that I have with lipid management being so easy to manage in the way that Adrian's talking about isn't even that people assess the risk. I wish they would. I wish they would understand things like number needed to treat and see how that applies to them in their exact circumstances. What bothers me, and I'm dealing with this within my own family, and I'll concede I'm just very close to this problem because of that, is how often it's thought of as though that was the best thing that could be done. So it's like, cool, we got the most appropriate way to prevent you getting a heart attack by taking steps to lower your LDL. When we just know we have way too much data to indicate that that is not your best way of reducing your chance of getting a heart attack if you're a high-risk patient due to things like insulin resistance syndrome. No, it's not. We're far away. It may, in fact, you can absolutely have the position of being very pro-lipid lipid lowering, be all on board with the lipid hypothesis, but you cannot be looking at all 5 markers of metabolic syndrome and feel like your steps to lower your cholesterol have done most of the work for you, when in reality, we've seen those hazard ratios. And so it's not even just that this might be one tool in the toolbox and how much we're going to argue about whether it's a tool or not. It's whether it's anywhere close, anywhere in the same ballpark as the real tools people should at least know should be considered more strongly because of how much more of an effect that they will have on their potential risk.
That comment resonates with me, and I hope I'm interpreting you correctly. I'm older than dirt. I'm 67 years old. I did my internship at Charity Hospital in New Orleans, and I remember doing hypertension clinic. And the assumption always was, well, we'll never get this patient to lose weight, so we just give them a statin. And how prevalent has that been in the medical community? I would say extremely prevalent. The assumption that folks won't change their lifestyle, that they won't lose weight. And if that is true, then why are so many people hanging on so hard to a model or a theory or a model that says it's all LDL?
This goes back again, because we have tools to lower LDL, perhaps we think about it too much. But what you say is totally right. We shouldn't assume, however, that's a default setting of most clinicians, I would say, that patients will never change their lifestyle for multiple reasons. Because yes, it's hard to cook your food. It's hard to learn to read labels. It's hard to make time in your agenda to go to the gym. It's hard to, we're not saying implementing lifestyle changes are easy. However, this doesn't mean we should immediately assume nobody will be able to implement them, or that it's not worth to try to do it. At the same time, lots of people, this is so prevalent that some people actually think that we can use pills as equivalent interventions to lifestyle changes. As if we can keep, like, this is, for example, just to change gears. Sometimes especially around controversies, I like to, draw examples from other fields or other sources. This happens very frequently with people living with diabetes who need insulin. Some people think that I can eat whatever I want if I match my insulin dose to it, and they typically see insulin, as a way to don't change your lifestyle. This is true. This is very frequent in people living with chronic disease. However, we shouldn't assume that because I am taking 1, 2, 3, or 4 pills, I can disregard and entirely ignore my poor lifestyle choices. There's no running away from it. So I think that even if these data, did not exist, we should be mindful that there is no enough drugs in the drugstore to patch lifelong poor lifestyle decisions.
If I understood you correctly, Nick, I think you said this is extremely context dependent.
Yeah.
And you guys are making go ahead.
I was going to say, I was trying to interpret and re-articulate what Adrian was saying, because I think it's really important, and it's important it's not misunderstood. Because neither I nor Dave nor Adrian are saying drugs don't matter and we should only do lifestyle. And I know some people like to run with that idea, that the idea of lifestyle and pharmacotherapy are at odds, rather than complementary parts of, making any individual or optimizing their health and risk factors. I think we all agree that there is a place for pharmacotherapy. It just so happens that given the culture and incentive structures in modern Western medicine, there's always pharma as the go-to. And metabolic health and metabolic medicine interventions get short shrift. And it has to do with the fact that they are harder to do. The research is harder to do, harder to fund, harder to recruit for, harder to execute, and then getting people to actually adhere to these interventions is harder. And so in this ecosystem we have, it just makes sense to go after the, quote, easy wins. If you have a metabolically unhealthy person with atherogenic dyslipidemia and a statin is going to reduce their risk, then you're going to prescribe that and not spend more time or providing people with more resources to fix their underlying metabolic dysfunction. which is why we have as a population a declining LDL level with innovations in pharmacotherapy. And despite that, we have not seen a decrease in deaths from cardiovascular disease, or the burden of cardiovascular disease, I should say. If you want to read more on that, Peter Libby at Harvard did a beautiful piece. I think it was in one of the Nature journals on, it's entitled The Changing Landscape of Atherosclerosis, where he says the burden of risk has now shifted relatively more off of LDL and ApoB towards just an underlying metabolic dysfunction, which is more refractory to treatment with pharmacotherapy. It just is. That's a fact. Like, you can't take atherogenic dyslipidemia and throw a drug at it and treat it. So what you do is you target what you can with the drug. And discussions around metabolic health, I just don't think are put as a priority. And I think part of the controversy that arises on social media has that as a nucleus. That there is a community of people who see how important metabolic health is and get very enthusiastic about it. And unfortunately, that gets expressed sometimes as conspiracy theories around certain things, or saying medications have no place when they do. So where lean mass hyperresponders come into this, which is quite interesting, is they do take this extreme of like, we tick every other box except for the one that will be addressed by pharmacotherapy, which is the center of discussion in medical circles, just because it's what can be targeted. It's the
It's what you've got a drug for.
It's the streetlight effect. You know that joke about a policeman sees a drunk man searching for something under the streetlight, and he asks the drunk man what he's lost. Says he's lost his keys, and they both look under the streetlight together. And after a few minutes, the policeman asks if he's sure the drunk man lost the keys there. And the drunk man replies, no, he lost them in the park. So the policeman asks why he's searching under the lamp, and the drunk man replies, well, this is where the light is. And it's just like that. Like, this is where we have a medication to target what is, at a population level, a risk factor. But just because the light is here, just because we have pharmacotherapy to address this risk factor, does not make it the most important one. And all this gets confused under a bed of terminology and jargon, things like causal, necessary, sufficient. And then people get confused, and then there's bickering because somebody will say LDL is causal, therefore it's most important, and somebody else will say, well, this person doesn't have cardiovascular disease despite LDL, therefore it's not causal, and they'll just confuse the terminology. Like, you can have something be causal, and you don't need to address it in every single person. So I don't know that I was actually simplifying what Adrian said, but I thought it was an important point that I wanted to reinforce in my own way.
Yeah, I mean, by no means lead the discussion, thinking that we think drugs are irrelevant or useless, or, I mean, I'm grateful we have very, wide armamentarium to address different risk factors, for sure. And actually, because of the patients I serve in my own practice, I prescribe lipid-lowering medication frequently. This doesn't mean I think they are the solution. And this, every time I prescribe anything really, I simply say, or I usually say, this is a plus. This is on top of. It's not the whole solution. This is besides implementing lifestyle changes. It's a bit like thinking that you can coffee drink your way out of never sleeping. Sure, is coffee helpful if you need to pull an all-nighter because you have the night shift at the hospital? Yeah, coffee will help. Is coffee a substitute for sleep? Well, of course it's not. It's something like that. It's lipid-lowering medication definitely help lowering cardiovascular risk for some. They are not enough to do so.
Well, Ford, I'd love to bring back that larger arc that you were saying to tie this together in regard to, there does seem to, I think one thing we can definitely all of us on this call can agree on is the expectation, the presumption that a patient is not willing to make lifestyle changes, I think is a travesty. It's a travesty. And I'm sure you've heard of Dr. David Unwin. One of the best talks I've ever seen in my life.
I love his very visual product.
Yeah, and he describes this perfectly. And he says he has the same stock speech he has with all the patients he sits down. And he makes it a choice. He says, let's talk about what the rest of your life will look like, and you could take on this medication, which you'll need to be on indefinitely. Or another thing we can talk about is that you could make different choices, change your lifestyle. These lifestyle choices could ultimately negate your need for having to be on this medication. And when he presents it that way, and it's very much the choices in the hands of the patient. I don't know if this is still the case, but at least the time that he was doing the talk at Breckenridge, he said he's never once had people go, "Oh yeah, the pills. I want to go ahead and head that direction." Right? I don't even want to hear. I don't want to hear the pitch for the lifestyle change. And he has so much amazing material that he's published, but he has a fantastic paper on all of these cases. I'm sure, Ford, you could publish a paper right now on all of these folks who, once they know that that's a possible choice, is it 100% of them? No. Is it a massive number of people who, if they know that that's an option that they can take, would love to hear at least the pitch, and many of them will take the pitch on? I think medicine needs to re-gear itself to make that an option. We don't have to make it a false dichotomy that there's only taking the full medication route, or you must be a gym bro and everybody needs to always be doing lifestyle changes, or that they can't be a combination of the two. But man, I've seen, being in this space in this amount of time, I've seen so many people who've improved their lives so much. So what I wanted to bring this back to real quick is the team that's on here right now, we already can tell you through the literature that we have published that, guess what? For most people who need to lose weight, and that's why they're going on a low carb diet, their LDL hardly changes if they're between, say, a BMI of around 25 to 35. If you're above 35, usually your LDL goes down, typically. But to the lipid energy model, if it's below 25, those are the folks that are going to see it go up. That's not most people adopting a low carb diet currently. Of those that do, who are metabolically healthy and don't have a medical reason, they usually can titrate up carbohydrates. That's in our first paper. And that's something that Nick eloquently showed in his Oreo experiment, that I showed in my white bread experiment from much earlier, and that many other people are showing in the groups. That draws the percentage down to a little bit more. And then you've got people like Nick himself, like many people I talk to who are epileptics, like type 1 diabetics, who they have a reason, medical reason, to be very, very low carb and therefore see the very highest levels of LDL. That's what we need this study for. These are the people I want to put in front of our biggest critics when they say, just get off the diet. If you're going to see LDL levels this high, please at least be with us, care about getting this data for risk. Help us raise money you want more people, you want longer spans of time, help us with the fundraising. We're trying to do that as much as we can right now. We already have another trial that's in the works. We're trying to get an extension on the current one. Sorry, I'm totally on my soapbox here, but I think I just have sort of a second win that's come with this next paper being published. And I feel so impassioned about this because Metabolic Mind right now is doing just the God's work on so many of these different studies that are coming out to show the incredible efficacy that, no, it's not a panacea, but for many people, keto is a new lease on life. And if the one thing that for many of these people turns out to be the biggest cause of concern, which is sky high LDL, they deserve our data. They deserve for us to get this in front of them. And so that's why we got to do this. That's why we got to get these studies done. Okay, sorry, rant over. Just had to go there.
So it sounds like you're not retiring from this activity anytime soon.
I guess not.
It's interesting. Because of the changes that you're bringing and the lightning rod that you are, folks continue to push on you regarding context. I'm going to flip it on its head and tell you that Jesus and I have received our not nearly as much criticism as you guys have, but we do get criticism within the low carb community because we do use medications. We offer low dose statins to patients that have plaque. not because of lipid lowering, but because of inflammation. Now, it brings up an interesting point to give you guys some perspective on low carb versus low carb. When we started bringing folks like Ken Berry and Eric Westman and Annette Boz on our channel, we began to find that if you've seen one low carb community, you may have just seen one low carb community. Eric, for example, said that his typical patient is 40 years old with a BMI over 35. Not at all the case for us. For us, our typical patient has already lost 35 pounds or more before they come to see us. Their BMI is less than 25 already. And they're in their 60s or older. And they're saying, hey, I've got some plaque. I just want to make sure that I'm doing everything I need to be doing. What do you think? So you're starting to separate these groups out, BMI 25 or less, BMI higher levels. Do any of you have any comments regarding what you would do if you were in Eric Westman's clinic versus ours?
Sure. I mean, one of the things I would emphasize, and this is something that I don't think we repeat enough, is that for someone with a high BMI, insulin resistance, hypertension, it is way more likely than not that after adopting a carbohydrate restriction, LDL will go down, not up. Mm-hmm. So the vast majority of cases of people who would benefit from carbohydrate restriction, actually, they are the ones who could say, why do I care about those data? Because what we've observed in many different studies, some in which we have participated and some totally independent, is that for that particular patient, it's more likely LDL to go down as they start losing weight.
No question.
So this is, I mean, this shouldn't be controversial. As I was saying before, most of my patients already have plaque. I wouldn't precisely, I mean, also data from Professor Budov, primary prevention looks very similar to secondary prevention for people with a CAC of 300 or more. So if I have a patient, maybe they haven't had a cardiovascular event, but if they have a CAC of 300, yes, of course, I would recommend a statin. But it's I wouldn't stop there. You know, if I have someone with CAC 300, BMI of 30, insulin resistance, triglycerides over 300, you know, the hypertension, yes, I would prescribe a statin all the time, but I would say, okay, why don't we at the same time start implementing lifestyle changes? I typically go for carbohydrate restriction as a first step, but I may choose a different thing for different patients. And most frequently, people who could benefit from carbohydrate restriction don't even face, high likelihood of seeing their LDL sky high.
I don't have anything to add here because, again, I try to avoid on discussions of medication per se. But I do want to add this, though, even though I try not to engage in it, I highlight and invite a wide spectrum of voices, including to COSI, which is raising money for the lean mass hyperresponder study, which include folks like Dr. William Cromwell, like Dr. Brett Scher, who themselves are very open that they go on a case-by-case basis, but they themselves, like Adrian, will prescribe statins depending on the context of the patient. So in general, I think there's nothing wrong with doctors being good scientists and digesting the data as they get it. You know, our job is to get the data and to make it available for them to make their own educated decision on the individual context of their patients and the patient relationship that they have. But nobody here, it sounds like nobody here, is anti-medication per se. It's just a matter of what the context is that makes the most sense to the care provider.
Let me add something there. Most patients, especially when they have to pay medication out of their pocket, want to have as few as possible. Most patients are unhappy about the lifestyle choices they make and they know are suboptimal. So this goes back to the point of why are we assuming people want to change their lifestyle? They actually want to, but very frequently don't know how to, or very frequently need guidance on what's the best strategy, or very frequently they need someone to join them in more likely than not month-long intervention until it becomes habit or part of your routine. So people are unhappy with their lifestyle very frequently. People are motivated to have less medication, not more medication, especially when they are paying for it. And this also should make us look more towards clinicians should be open, willing, and encourage patients to implement lifestyle changes. I mean, one of the reasons why me and my research have been, recently focused our interest on food addiction is because food addiction is perhaps a scenario where people want to change their lifestyle, but they really can't because of multiple reasons. Because, well, the food itself, ultra-processed food itself, can be or produce addictive-like behaviors. This doesn't mean we could solve every problem with lifestyle changes. And if to go perhaps full circle and to go back to the keto CT trial, there is this paper which I knew of for the very first time watching a lecture from Dave Feldman way before he knew I had existed, which is, I think, Jack and Bartlett's 2016 paper with Framingham's data. And the paper is titled, "Is Isolated Low High-Density Lipoprotein Cholesterol a Cardiovascular Risk Factor?" We could title, this paper's title could be somewhat very similar. Is isolated high low-density lipoprotein cholesterol a cardiovascular risk factor? Because it's really the very first opportunity in which you get to see this risk factor in isolation. And it's relevant because it makes us question the way most patients are getting healthcare now, but at the same time doesn't negate there is, a wide range of very useful tools for reducing people's cardiovascular disease.
Which brings me back to part of why I wonder why there's so much, you guys are catching so much grief. I think most lipidologists, and maybe I'm naive, but I, in my heart, think that most lipidologists probably still feel that metabolic disease is probably more important. I don't know why there's so much debate over this issue. I've got 3 or 4 things, and we've got limited time. So one of them is the Mendelian randomization studies. I see you laughing. I think you already know my...
Forward to this moment, and I would like to hear Adrian wax eloquent on MR. That would make me happy.
Please do.
MR are slightly better way of doing observational studies. And there are, as with any other method, there are good papers with MR and there are awful papers with MR. And I don't want to sound like all MR papers are, untrustworthy. Now, that said,
Adrian, do you mind if I interrupt you for a sec? Because it's quite possible a lot of people have no idea what we're talking about.
Yeah.
Let me make the Steelman pitch for MR. So Mendelian randomization studies are thought to be a new way to determine causality because genetic variations across all these populations, for example, genetic variations in LDL levels being a little up or a little down, and the corresponding association with cardiovascular disease, even at tiny little levels, can give us enormous data because you can see it at these huge population levels, so that you can you've got like millions and millions and millions of data points, so that even though it's very small amounts of changes, there's the expectation that from that we can make causal inferences, especially if they happen to associate in a very consistent way with each other. So how it's often described is that this is like a natural randomized control trial, because these people didn't do a particular intervention. They started with it at birth, it's presumed, and therefore it's the best evidence. I hear this all the time. Mendelian randomization is the best evidence for causal inferences that exists, even better than true randomized control trials. How'd I do? Was that a good Steelman pitch? Would that be fair?
Yes, but people go further. They say it's a lifelong randomized control trial.
Yeah.
And they typically say it's the best available evidence. There are all methods have assumptions. This is something we should say. There's no perfect method for no research question. All methods have assumptions, and MR studies are not the exception. Now, you can already imagine that, okay, let's say I inherited a genetic version of whatever gene implicated with lipid metabolism. Let's go for, the now very famous PCKS9. I inherited the risk version, and I am a data point in a randomized control trial. Sorry, in an MR study.
You have PCSK9 disease type.
Yeah, PCSK9 disease type.
Oh,
So,
interesting.
no, I don't, but let's imagine I do.
Okay.
MR studies assume that my LDL will be higher than those who didn't inherited the genetic variant throughout my whole time. They are blind to me making different dietary choices or receiving different medications. But above all, one of the key assumptions of Mendelian randomization studies is something called, it's a horrible name, I'm sorry, but it's something called horizontal pleiotropy assumption. And this is a very fancy way of saying that the genetic variant you are studying is only allowed to change the exposure you're interested in this case, the outcome you're interested in this case, cardiovascular disease, through the exposure you're interested in, which is high LDL. In other words, PCKS9 is only, for the methods to work, should only impact your risk of cardiovascular disease through high LDL levels. And we know for a fact this is not correct for any of the genes that have been studied in Mendelian randomization studies. Because exactly as you pointed out before, Dr. Brewer, you can prescribe statins because you're after inflammation, not after LDL. So we know that Mendelian randomization studies, for example, studying HMGC gene, they may be in this Mendelian randomization structure where, people with variants of HMGC, gene have higher LDL? Well, yeah, sure. Does this gene affect your cardiovascular risk only through high LDL? No, it doesn't, because it's also implicated in inflammation pathways. PCSK9 is also involved in carbohydrate metabolism. It's also involved in inflammation pathways. ACLY, which is another very studied gene because of bempedoic acid, is also implied in your endothelium response to inflammation. So we know for a fact that these genes break the horizontal pleiotropy assumption, because there isn't a single gene, perhaps this is perhaps hyperbolic, but I think it's intuitive that almost every part of our biology has more than one function, has more than one task. And that's why it's so hard to find something, to find a gene that influences a health outcome only through one pathway. That's the core assumption of Mendelian randomization. And there are meta-analyses of genes studied in Mendelian randomization. And you can, I swear to you, just grab one gene, go to PubMed, and whatever gene, fill in the blank, cardiovascular disease, and then write inflammation or carbohydrate metabolism or insulin resistance, and you will get a lot of hits that explain how this particular gene is linked to cardiovascular disease beyond LDL blood levels.
So, Nick, which one?
That's a very famous one.
The
LDL cumulative exposure.
No, let me share a screen if you don't mind. I just want to make a point. So I'm, for reasons including what Adrian has said, but also reasons beyond that, not a big fan of MR. However, I think just in general, and this is games of fair play and debate, if you're going to use a source of evidence, you should not apply double standards to that source of evidence. So there are signals in the MR literature, and one was this paper by Schmidt et al., the drug target. Oh, actually, what is the main title of the paper? It was in Nature Communications. It's CETP as a drug target for cardiovascular disease by Schmidt et al. In 2021. And they look at Mendelian randomizations, looking at cholesterol ester transfer protein, but also PCSK9 loss of function. The funny thing about PCSK9 is you always hear, oh, if somebody has a PCSK9 loss of function, they're the genetically gifted one. They've won the genetic lottery. You hear that term because they have decreased cardiovascular risk, which is true. They have decreased cardiovascular risk. But as Dave has pointed out, including in his talk with Simon Hill on the Proofs podcast with Bill Cromwell, it's like, well, we don't see a clear signal of these people living longer. So what's the trade-off? What are we looking at and what are we missing? And so a funny graph, I'll now share my screen. Do you see my screen?
Yeah,
there we go.
Yeah, so if I go down to figure 3, I think it is, and this is looking at MR. So the drug target Mendelian randomization effects of lower CETP and PCSK9 concentrations on clinical endpoints. We'll see the full size image. All right. You see my screen? Let's make this. All right. So the right is PCSK9. Let's first look at cardiovascular outcomes. Coronary disease. All right. Decreased risk. The odds ratio is 0.69. Any stroke, decreased risk. Ischemic stroke, decreased risk. Large artery stroke, decreased risk. With good odd ratios in like the 0.6, 0.7, 0.8 area. Now let's go to non-cardiovascular disease. Type 2 diabetes, actually bordering on trending towards increased risk. The confidence interval lower bound is at 0.99. But scroll down. I mean, asthma is interesting. Look at this. Somebody want to describe what they're seeing here? What?
Sure.
Huge increase in
increased risk for Alzheimer's.
Yeah.
The biggest effect viewed on this graph is a increased risk for Alzheimer's, odds ratio of 2.43. It's striking if you're looking at the graph. Now, why is this not talked about? Let me go ahead.
Absolutely. And I'll share my screen if you this is my scientific reference manager, and you should be able to see it now. Look, I mean, PCSK9 and carbohydrate metabolism, PCSK9 and thrombosis and hemostasis. Beyond LDL, what role for PCSK9 on triglyceride-rich? All of these, one of them could be enough to say you cannot use these variants in this gene for this particular purpose because you have the same gene affecting the outcome through more than one way or parallel to your LDL hypothesis. And this will be true for, again, ACLY, for HMGC, for any gene, because genes in our biology have more than one task. So it's not surprising that you have perhaps better risk for one thing, but much worse risk for another.
Yeah.
And that's why, in general, Mendelian randomization studies are definitely far from being a lifelong randomized controlled trial. You don't have to take my word for it. I mean, the father of Mendelian randomization is George David Smith. He very recently kind of pushed hard the brake on Mendelian randomization studies because they are being very, very, very much misused. He has a fantastic technical but fantastic lecture called Noodles, No Nulls, and Numbskulls to outline why these methods are very problematic, especially today. And in general, I mean, and this is also something George David Smith recognizes, Mendelian randomization is just a different term in our field for something econometrics has known for a while, which is called an instrumental variable. If you ask any econometrician how impressed they are when they read a paper with an instrumental variable, you will likely say like, yeah, okay. It's a better than nothing approach. So I think it's econometricians in general don't like instrumental variables because they are already familiar with how they can be problematic. It's very ironic that something that would raise some eyebrows in econometrics is considered by some to be the best possible randomized controlled trial. For someone who wants to dive longer, there's a very nice paper from Miguel Hernan, who is one of the legends of causal inference, titled Nature as a Trialist, and outlines why you shouldn't, make this equivalence between Mendelian randomization and a randomized controlled trial. Not because genetic variants are inherited at random, which is of course true, means you can, substitute one for the other.
Which brings up my last point. Why are so many people on the other side of this debate reacting the way they are? I have to tell you, if this was about a year ago, I was on the phone with Jesus and a fellow named Nathan, who was channel manager at that point in time. And I was saying, guys, I've read the Mendelian randomization trials, studies. I'm not impressed. And yet they're being presented and they're presented so often as, okay, that's the trump card. I throw the MR studies down and nobody can argue with me anymore. Well, no, they can. And I'm so glad you're the first guys that I've heard throw shade on the MR studies, and I greatly appreciate it.
Can I tell you a secret, if Adrian doesn't mind my sharing, because this literally came up a week ago. A week ago, there was a clip. I'm not going to call them out, but there was a couple influencers that were talking on a podcast, and I gave a respectful reply. And one of them was kind enough to
was Patrick and Lane Norton.
Yeah.
I
saw it.
Thing me, Dave. Yes,
I saw it.
Nick always does this. Nick always just outside. I'm always trying to do a polite approach, and Nick. Anyway,
there was a lot of politeness in that interaction.
Yeah,
but it got where you needed to get.
Wrote back and did exactly what you just said. She said, "Listen, Mendelian randomizations. There's just no arguing with it. You're talking lifelong." And so what I did was I was like, okay, fine. You know what? I'm going to use their math. I'm going to use the exact study she linked. I sat down and I did the math. I'm literally looking at it over here on the spreadsheet. And again, if you're talking these teeny tiny, as I just mentioned, teeny tiny differences, right? So it goes from a difference of the lowest amount was 2.63 milligrams per deciliter per year versus PCSK9 loss of function, which actually was a lot less than I thought it was going to be in this study, is a difference of 16.69. So a drop of 16.69 milligrams per deciliter per year. And it has this nice clean line that's got the dots along the way. And I'm going to be honest, every time I see anything involving metabolism, full stop, that throws up a chart that's a scatter plot and it has this like perfectly clean line, I get super skeptical. I can't help it just because I find that virtually almost nothing works that way in nature that's at that level of complexity. But for applying it to the present lipid hypothesis as is presented to us, which is time versus exposure. It's presented because if you look at the 2017 EAS paper and pretty much anybody else who talks on it, they say, look, it is like down to a science. It is accumulating and it's at, I want to say it's per 1 millimole, so it's about 38 point, et cetera. And this paper does the same thing, shows the accumulation of risk. Well, I took it apart. I looked at these accumulations, and I looked at the longest distance between two of the data points that they have of two of the genetic variations. And it's, if you apply it to a 77-year-old average age of, say, somebody who lives that long, it's a fairly large amount. It's 700 milligrams per deciliter. So over a lifetime, between one distance, other distance, an accumulated difference overall of 700 milligrams per deciliter. But I'm sure Nick and Adrian know why it is that that would absolutely pop out at me, because it happens to be about the same amount of difference between keto and Miami Heart in the 4.7 years. So they've accumulated the same amount of difference in LDL cholesterol that would be considered very definitive for the lifelong range of this lower amount that you would see in a Mendelian randomization study.
Yeah.
And I was talking to Adrian, I was like, I need to just make a video on this to kind of send back their direction. And Adrian gave me sage advice. It's like, the problem is you're already giving so much credit to the underlying assumptions of Mendelian randomization studies in the first place. It's not even worth it. And I think he's right, because that's actually against my existing opinion. I already don't love how much there are underlying assumptions to all of these things with lipidology. That's why I wanted to just go and get a study with some direct data, directly get exactly what the LDL is and its association with plaque without underlying assumptions, without modeling, without any of these other aspects. I'm not saying that there's not a place for that. And Adrian's fantastic and has utilized models and so forth. But what I love about Adrian is he already knows the future critiques that are going to come and already bakes in a lot of that into the existing papers we have. So he already anticipates what are the common reasons people might push back and correctly finds the best way that we can set them up. But me personally, I am really old school. You can't tell me how the engine's going to run. I want to see the test drive. You can't tell me it's going to make it from one end of the country to the other in your models on your computer. I want to actually see the prototype, because I've seen a lot of prototypes never make it into production. And my end.
Let me expand on something. Let me expand on something very, very quickly, but I think it's very important. George Davis Smith, again, the guy who came up with the name Mendelian randomization, the pioneer of these methods in biomedical sciences, typically explains MR as saying that the underlying assumption is the gene environment equivalence assumption. You're assuming that the gene version you inherited is a good proxy for the environment you're trying to mimic. And very frequently he has these, he presents this example on, well, you can have a low BMI because you're lean or because you lack one leg. And sure, both will result in a low BMI. The MR method will be blind to that difference. Will treat you the same. And of course, in other words, this will be as good as your definition for the environment you're trying to study. And to go full circle, none of the cardiovascular outcome data that you can get for a Mendelian randomization study comes from a context with lean people restricting carbohydrates. So it shouldn't be surprising, because this, as we mentioned at the very beginning of our conversation, this context is new. This is the very first time you have good data on lean people restricting carbohydrates without other cardiovascular risk factors. So it shouldn't be surprising that even if Mendelian randomization studies lacked the problems we already discussed, because the outcome data comes from a different environment, a different context, they don't necessarily represent the association you would see in a different context. The gene environment, equivalent assumption does not hold for LMHRs. So yeah, it's perhaps to try to bring it back to where we started, but that's one of the reasons why, MR studies are problematic and not necessarily representative of what you should expect for lean, otherwise healthy person restricting carbs.
I probably should have done this at the beginning of the conversation. But on Mendelian randomization, but for those in the audience that have stuck around through this, if you're confused about it, just to let you know, I was too when I first started hearing about it. It was not a thing when I was doing epidemiology at Hopkins, and it twisted my head quite a bit. And I'm going to try to give a thumbnail sketch of it, and you guys correct me. It's based on Gregor Mendel. He made the assumption that traits, genes are distributed at random. So if you have a gene which causes LDL to go up, you would assume if LDL is the cause of cardiovascular disease, people that have that gene are going to have more cardiovascular disease. And you fast forward 40 years from when I was at Hopkins, I'm seeing patients on a regular basis. Before we started seeing so many lean mass hyperresponder patients, we had a whole lot of FH patients as well, and still do. And we don't see, I mean, Jesus loves to tell me, well, Ford, that's a quote expert opinion, which means it's the worst type of evidence. And it's true, but he's seeing it as well. We just don't see a whole lot of people with FH having huge increases in risk. We see it on the FH page, the page where all the people that have FH get together and they say, yeah, we're in bad shape. Not so much. I mean, we get tons of those folks, including a subpopulation of folks located in Canada with really, really high numbers.
Anyway, absolutely. And just to emphasize something there, you're assuming that these high LDL will cause more cardiovascular disease. The thing here is that all the data comes from studies where pretty much all high LDL data meant insulin resistance. That's why it's so difficult to tease apart. Because these cardiovascular outcomes have no, I mean, and for years and years and years, people assumed that you could say all high LDL levels were made equal, mostly through insulin resistance, but it turns out that's not the case.
Yeah, can I illustrate this very simply? So Ford, imagine this. Imagine the whole world is just two islands. And on one island are people who are shorter, they're blonder, and they've got blue eyes. And on another island, there are people who are taller, they have brown hair, and they have brown eyes, right? And on this island, the ones who are blonde, they love to eat pizza all day long, and there's just a higher prominence of metabolic syndrome, right? And on the brown hair island, they have a whole food diet. Now, I'm setting up Adrian. Adrian, would we find that there's an association in Mendelian randomizations between these two islands with, say, brown eyes and higher LDL?
Absolutely.
We would, right?
Absolutely.
Would we also see an association between brown eyes and higher cardiovascular disease?
I mean, it's exactly, yeah, if you want to be super
Or actually, I'm sorry, the other way around.
Yeah, exactly.
But this is what you're getting to. They're not actually truly randomly distributed.
They're not.
The genetics are not perfectly distributed across all countries everywhere. So if you've got locales for which there is a higher clumping of certain genetics, they're going to show that association if the lipids themselves change from the environment and not from the genes. That's the whole point. That's why this is a bit frustrating, because if I can make you, Ford, if I can kidnap you and I can make you get metabolic syndrome because I feed you a terrible diet, will I change your lipid profile? I will. If I can change your lipid profile through bad diet, then where you live and the environment that you're in and the family and the culture and everything that you're a part of, that's going to trip up things like Mendelian randomizations.
And at the same time, it usually overlooks the fact that we don't only inherit the genes from our parents. We inherit, what's in the fridge. We inherit access to education. We inherit, lifestyle traditions, and so it's also covered by that. That's a whole other set of limitations for MR studies geneticists would bring on, that clusters of genes are not necessarily inherited at random. But again, I mean, too long didn't read or too long didn't listen, MR studies are far from being a lifelong randomized control trial, especially for something where you have more than one context for high LDL.
And if I may, I have been biting my tongue the whole conversation, and I love it. I mean, I'm learning a lot as well. And I'm gonna give credit to Dr. Brewer's experience. But I'm just going to give you some. I want to ask you a question. Because I was amazed by this statistic that I just saw a few weeks ago. Turns out that in the US, only about 20% of people are following a low carb diet, and only about 7% of people are actually on a ketogenic diet. And now talking about the impact or the role of LDL on cardiovascular disease, would you say would
people are on a ketogenic diet
7%
in the population?
in the US population?
I doubt it. I really doubt it.
You
Oh,
doubt
that
it?
seems very high.
That's a huge number. I doubt that.
Well, I'll
our
double
individual
check.
I mean, let me bring here another. I mean, there's this very cool study.
You're actually thinking that is less than that, right?
Oh, yeah.
I'm not
Okay.
doubting that you read this somewhere. I'm now very curious about their methodology, because I think if 7% of people in the US report being on a ketogenic diet, very telling about what people think about ketogenic diet. That's why I got stopped in my track, because
but regardless of the exact number, we can all agree it's not most people. Most people are on the standard American diet.
Oh,
right?
yeah.
Okay,
Definitely.
so that's the whole premise. Would you say that for somebody to really understand what a lean mass hyperresponder is, and if they are a lean mass hyperresponder, the first step is to go on a low carb or ketogenic diet? Is that a correct assumption, or am I wrong?
Well, that's go ahead.
I mean, from a clinician's perspective, when I see very high LDL, I don't assume LMHR as the most likely explanation for it. So if I see very high LDL, well, in my practice, but this is of course selection bias, I assume that the most likely explanation for very high LDL is insulin resistance. And then I think that another very likely explanation is FH, because as I keep saying, not because LMHR exists, FH stopped existing. So I also need to consider that's a likely explanation. If those things are ruled out, and you see the triad, the very active person, very strict, and definitely restricting carbohydrates, well then yes, sure. But that's why Dave Feldman basically discovered unicorns, because when we analyzed every possible lipid panel on NHANES, there were only 3 people meeting the triad. So out of almost, I think it was 90,000 lipid panels. So it's definitely rare. And again, please, not because you saw high LDL, the most likely explanation is LMHR. No,
I agree with that. But my whole point is, if most people are not on a low carb ketogenic diet, how many people with LMHR are out there that we don't know of because they haven't done that first step? So that was my question. Is that in order for somebody to understand or think about, okay, that might be me, but I have never been on a low carb ketogenic diet. Should that be my first step to find out? Or should I assume that it's just insulin resistance first? If I haven't done a low carb diet or ketogenic diet ever.
So before you answer that, let me just make a comment supporting the question. And it gets back to your comment, Adrian. It reminds me of the old statement. When you hear hoofbeats, you think horses, right?
Not zebras.
Yeah, unless you're in Africa, continental Africa, and you should probably be thinking zebras. So if you look at our population, 5 years ago, when I saw an LDL greater than 180, I usually started thinking FH. I covered it a lot. There was a lot of discussions. There weren't a lot of docs that were familiar with it. These days, I would guess, I don't know, Jesus, what would you say? 5 to 8 lean mass hyperresponders for every FH patient that we have now.
Yep.
Yeah.
And it's because,
let me tell you something.
Go ahead.
Part of the point why we think this is normal physiology is because of something that has been labeled the gym hypothesis. We believe the phenotype is inducible. And for example, something I've observed in some of my patients is they start overweight, LDL comes down. Once they are lean, but stay on carbohydrate restriction, now the LDL comes up. And we believe that this is normal physiology because basically if you grab random lean people at a gym without the LMHR phenotype, you can induce the phenotype by restricting carbohydrates and increasing physical activity. So that's why we think it's normal physiology, because it only makes sense from a telenomical point of view that we would have physiological adaptations to make us more efficient for oxidizing and transporting fat energy when there's not much carb around. So that's why we think it's perhaps a piece of human physiology that was overlooked for decades of lipid research.
And that's actually where we experienced a lot of pushback on the mechanistic end initially, is at first everyone was saying, oh, well, lean mass hyperresponders have this high low. There's not even a lean mass hyperresponder. People have high LDL, they're just eating too much saturated fat.
Yeah.
And our very first paper was with a survey that I was able to get together of a number of people that sure enough did show that BMI was strongly predictive of how much of a change in LDL you would see going on a low carb diet. And then eventually, Adrian had the superstellar idea of just going ahead and doing a meta-analysis, which he's first author on, which we published from last year, for 41 randomized control trials. And these are folks who weren't already keto. So the self-selection aspect goes out. They were randomly assigned. And all of these meta-analyses were with studies that had at least one arm that was low carb or ketogenic. And sure enough, by the graph looks amazing, and how predictive it is on the LDL change with what it is. Now the new pushback, which surprises me in the wake of that meta-analysis, frankly, the new pushback is that there's some genetic abnormality for some lean mass hyperresponders, but that it's rare. So the reason this gym hypothesis experiment is so important is because we want to intentionally see if we can grab a number of people who are keto naive, they've never been on the diet, just like as described, it's just people from a gym. If we could just choose them, if we could pick them out and classify them, could we turn most of them into lean mass hyperresponders? And that would be such a massive thing because think about it. There's the only other kind of lipid panel that has a pattern to it that's very recognizable is nearly the opposite with metabolic syndrome, right? To actually get an arrangement of 3 lipid markers that are very rare all on their own, an LDL above 200, an HDL above 80, triglycerides below 70, it's a pretty strong claim when, as was mentioned earlier, out of 90,000 people in NHANES, we found 3, right? Out of 90,000. That's so massive, and it could really tell us a lot about human physiology, which is why we're so excited about it.
So you're saying you're about to go ahead.
So go ahead. Dr. Blue.
So you're saying in this Jimbro analysis, you're about to look at the question that Jesus raised. Just how common is this?
In privately,
Yes.
we think it's not just that it's common, it's that it's actually under normal circumstances going to be the majority of people who are metabolically healthy, who go very, very low carb and come to a place of being very powered by fat, with, of course, the caveats that some degree of genetics may actually be the reverse. They may actually, in some abnormalities, they may not exhibit this phenotype, but that's more the exception than the rule. We're betting that this is the rule.
Because today, the standard is 86% of the population with insulin resistance, and the standard guidelines saying 50% carbs of your total intake. That's the standard
Yeah.
today. But picture yourself, 15,000 years ago, most people were lean, and most people, at least for some part of the year, did not have access to carbohydrates. So they were, you had lean people exposed at least during some time of the year to carbohydrate restriction. It would only make sense that your physiology evolved a system or an adaptation to upregulate transport of energy as lipids to meet with demands. So that's, that's, however, it's also understandable. It could have been a piece of human physiology that went overlooked.
So I told one of you, I think it was Dave, I usually am low carb, not keto. And we were toying around with my diet. I went carnivore for a couple of months. My LDL went from its usual 55 up to 182.
And it was me, and I did immediately go to, so is your diet, your low carb diet, typically full of a lot of fiber, like leafy greens and so forth, right?
Yeah.
And that's why changing over to carnivore, I wasn't surprised at all.
To use me as example, for example, I am lean, but not as lean as Nick. And I am also mostly low carb, well, keto, you could say. However, the only time I've pushed my LDL above 280 was if I go full carnivore and do lots of exercise.
Yeah.
Otherwise, I mean, and it really requires the exercise part. If I am only full carnivore, my LDL would stay 210 to 120. It's only when I increase energy demand by a lot that I push my LDL, to the 280s, 290s.
We got to do one tiny geek aside. You meant more cardio. Cardio meaning your cardiomyocytes are turning them over faster. The only reason I make that distinction, is the guys on the call know, is resistance training is kind of typically a lever to take it down, which we won't get into the nuance unless you want to, but it is a distinction. So that's why gym hypothesis is, if I could choose, if I could walk into a gym right now, I'd get the runners, the cyclists, the people who are into cardio and not into lifting. They would be pulling that lever the hardest, on top of being lean, on top of getting them as low carb, those three together. And I've got myself a solid Nick Norwitz type person. And then I can expect those levels to get really high. And incidentally, none of us are nearly as lean as Nick Norwitz. Probably nobody watching this right now.
The irony of my highest ever LDL. This was the beginning of the process. I had just met Dave, and my LDL had gone, 300s, 400s, 500s. And at the time, the lipid energy model was in my head, but I still thought it would be, one lever, maybe even equivalent to, but not greater than other things that are typical, saturated fat being one. So I decided to get the cholesterol and saturated fat out of my diet as best I could. So I cut out all egg yolks, all dairy, all red meat. And what ended up happening is, instead of going down, my LDL hit its highest level ever at 545. This was eating 86%, I think, unsaturated fat. So a 5.67 ratio of saturated to unsaturated fat. My fatty acid profile in my diet had less saturated fat than a lot of olive oils and more PUFA than olive oil. So in terms of fatty acid composition, this should have driven down my LDL. One of the reasons it went up, or the reason it went up, I think, is because by virtue of I'm not having any butter or any cream or even egg yolks, it's the only time in my life I've actually eaten just egg whites, I lost more weight. So I got even leaner. And then my LDL went up. So anytime I lose weight, LDL goes up. Anytime I'm more active, LDL goes up. Anytime I'm less active or gain weight or gain body fat, so if I'm stressed on a clinical rotation, sleeping poorly, altering my fuel partitioning, being less active, sitting in a chair, all those unhealthy things drive my LDL down. And I can't even imagine what would happen if I went to the nurse's station and ate some of their donuts. It would just tank my LDL, per the Oreo experiment.
And think about this. Think about this, Ford. We have this model that's doing the things Nick just mentioned, the thing you just mentioned, the thing Adrian just mentioned, we're all different people in our different parts of the world right now. And the model keeps correctly predicting a lot of these. And we'll emphasize, we don't think that the model is complete. We think that there are other levers, such as fiber, for example, such as genetics, et cetera. But models, while being incomplete, are all about competing with each other on how explanatory they are. And I'm dumbfounded myself by just how much this keeps being that accurate in these exact things we're describing across the board from so many different people. Not everybody, but so far, that's why we think the GEM hypothesis experiment is going to be a lot of fun when we eventually can get it together.
Sounds good. Jesus, when you quit biting your tongue and jumped in, I thought you were going to say, "Hey guys, it's time's up."
Well, that's what I'm about to do now. And I'm just gonna say one more thing before I tell you that we're limited on time. I feel like a black sheep right here because my LDL was somewhere between 80 to 90 when I was on a fairly not necessarily high carb diet, but not a low carb diet as I am right now. Started low carb diet, crank up the resistance training specifically, and I think it went like 120. So still has changed, but not a significant change like to be on the popular kids group.
No, I mean, life is not a competition of raising your LDL. And to also to give credit to something that's very frequently brought up by the other side of the aisle is, okay, maybe you were an LMHR, but is it actually necessary to keep your LDL high? Or perhaps you could be even better if your LDL is lower. Well, maybe we would like to, test it out. But in the end, I mean, for some people, if someone wants to reduce their LDL and they don't have, like a super strong reason to stay restricting carbohydrates, you can cycle carbs once at a time, certainly not go for Oreos, but Nick has this very fantastic video on 6 ways to lower your LDL. And that's also an option, however, some people don't have that choice. And yeah, I mean, there's no pressure. Please don't feel pressured to bring your LDL up. It's perhaps just a marker of something very obvious, which is how lean you are.
Yeah, I think focusing on what is one would imagine is metabolically healthy. I think there's a lot of things we can agree on. And not chasing numbers, I think, would be broadly a good idea. Like it's not as if, I'm going to be clear, it's not as if between individuals, LDL will be because my LDL can hit above 500 does not mean I am leaner than someone else who is a lean mass hyperresponder, their LDL hits 200. So there is individual variability on how much the lean mass hyperresponder phenotype will manifest. And we are in the process, without naming group names, of rigorously investigating what those predictors might be, going beyond the genome, talking about microbiome, proteome, transcriptome, some really exciting projects that hopefully in a couple of years we'll have some pretty high grade publications to share with you. So things are really, you have no idea. They're we're at a catalytic moment. Lean mass hyperresponder lipid energy model literature is really going to take off in the next several years.
I'm just happy because this is the first time. Truly, this is the first time where those two main questions I bring up over and over again, presentations, have answers in the literature, at least at these stages, right? So the question was mechanistic. Again, so much appreciation for everybody, including many people outside of this Zoom that also helped us out on getting the publication. And the other is risk. And as of this moment, we have both of those on hand. And to Nick's point, we're excited about what comes next, what we can make happen come next. I did want to throw something out to you, Jesus. So if you want, you could do an N of 1 experiment and pull all those levers I was just talking about. If you want to take say 2-3 weeks, go full carnivore, keep it, drop off the lifting just for a couple weeks and see what happens. I'd be very curious.
You believe I'm gonna do that. What's that, Nick?
It's calisthenics a lot. So I don't do focused cardio, and maybe it's just how I'm wired, but I do a lot of push-ups, chin-ups, muscle ups, burpees, those kind of things. So in the realm of appropriate strength training that I think would still be compatible with manifesting a lean mass hyperresponder physiology, I think calisthenics would be totally appropriate. Dave can.
Yeah, well, and that's what I do. I mean, it's not like I'm running a lot. It's mostly just what you described, Nick.
Yeah.
And again, this is for experiment purposes. We're not advising Jesus to become a lean mass hyperresponder. Just that is for this is what the gym hypothesis is about, is determining how much this is true physiology.
You guys are still getting beat on a lot, aren't you?
We're a lot of this is just to kind of save ourselves the headache. Like, certainly we know amongst ourselves what our opinion is. You guys know what our opinion is. But is it true that we probably, multiply the caveats 3 or 4 times comparatively before? Certainly I do. I know that people who follow me closely already know this, but it's true. I've had, and I know this has happened to Nick too, I've had clips of mine taken way out of context, and it's been especially frustrating. And so therefore, whatever, I make sure that nearby, anytime I've said something, that's the best I can do, is just, make sure everybody, if I err on the side of saying it too often, fine, at least we get it there.
Nick knows, or getting your face put on nonsense memes, which is just guys.
Yeah, well, recently when the Jack Advances came out on the lean mass hyperresponder match analysis, I did a video, and in the video I open by presenting 2 extreme positions, which I say I disagree with. So I'm saying this is wrong, and this other extreme position is wrong. So I'm saying this is something I'm about to say, and it's completely wrong, and I say that thing. Then a militant vegan takes the clip of the thing I said, I don't believe this, and presents it. And takes a screenshot of me looking very intense, saying, I'm not even going to say what I said because it probably just happened again. But it's just like going out of your way to intentionally misrepresent. I probably should just get habituated to it. But I showed that to Dave, so over it, because it's like, can't believe Nick said this. And everybody's like getting involved, like, oh my God, Nick's an extremist. I'm like, I literally said, this is an extreme thing I don't believe. And they just took the whole beginning of that part and just left it out. So it sounded like I believe the thing I said I exactly didn't believe.
And we get a lot of that, like people just commenting without actually looking at what we are saying. It's not like we're promoting cigarettes. It's like, guys, we're asking questions, right?
And it's I need to emphasize this on Nick's behalf. He led an editorial from 3 years ago, an editorial with the likes of people like Ronald Krauss, with the likes of with many other Dream Team people that absolutely advised caution when approaching the high LDL, which is why it got so many signers on. That alone should have mega blocked everything in the future and from then on, as to whether or not he believes that the sky high LDL is something to be, is something he's confident is perfectly fine. I think Nick, you have done such an amazing job of regarding yourself while making all of this content over and over again. But there's just no getting around it. Sometimes people do exactly what he's describing.
And just so you know, we're plugging your videos and your articles on the description of the video. I think I saw that editorial, but I'm gonna put it on the description too.
That is the #1 most ignored thing I've ever published.
No matter what,
really.
Yeah, Adrian's meta is ignored quite a bit, but I think your editorial, I don't know, it's a tough competition between those two, right?
And it's usually the first thing I highlight when I'm trying to build a bridge. Like when I first reach out to Lane Norton, I'm like, just read this editorial. It's like a couple pages, just so you understand where we stand on this. Like, if you're gonna talk about risk with respect to this phenotype, please represent the idea of the authors. And I went out of my way to put together this team. I even asked Peter Attia for people he involved in the team. He said Ronald Krauss. We got Ronald Krauss on the team. Present it. It's a couple pages. Not that hard to read, and all of our detractors just sweep it under the rug or just completely ignore it. It's like they're trying to misrepresent. It's quite appalling, actually. So, and then it's a competition between that and Adrian's meta, because people love to be
that article actually received pushback from some people in the low carb community, because it said you should consider statins for certain cases. So I mean, it's
You get I get it from both sides. It's called being provocatively reasonable. Then you just get it from everybody. So anyway,
apparently nuance is something revolutionary that causes a lot of controversy. But anyway,
we
A
will.
couple of quick questions for Nick before we go. Number one, how about your Massachusetts State push-up record? Is that still standing?
As far as I'm aware,
Good
that
for
was
you.
10 years ago. Yeah.
Just asking. You were talking about doing push-ups, and I've been wanting to ask you that. Second question is, you've done a couple of good videos on eggs recently, and we were discussing that before we went on the air. Jesus has had me eating a whole bunch of eggs.
Yeah.
Can you give us a 30-second preview of it?
I mean, this was a follow-up to a video I did earlier in the year on a hormone called cholecyn, which is, people probably know by now that dietary cholesterol doesn't really impact your circulating levels. And they discovered the mechanism by which that is, whereby cholesterol stimulates the production of a hormone, cholecyn, which inhibits cholesterol production by the liver. So it maintains a homeostasis. And I love the name of the hormone. It's very clever because cholecyn, cholesterol inhibitor. That's why it's named.
Mhm.
So it's quite clever, but there was some discussion on Instagram about that video, and I had another video in the bank that I just ended up releasing, which was an experiment of me eating 720 eggs in a month and applying lipid energy model physiology to it. So basically, based on what we know, even eating that many eggs probably shouldn't change my cholesterol much and should be dominated by lipid energy model levers. So what I did is, for the first 2 weeks, I just ate 720 eggs. My cholesterol didn't really change. Then I added just a few blueberries and bananas, like 60 grams of carbs. So I was still ebbing in and out of ketosis, and my LDL dropped by 18%. And this was not even like, it was low dose. So I was 60 grams of carbs. I was still kind of keto. I actually wanted it in that moderate range to see what effect it would have. But bottom line, you pit 720 eggs per month versus having a banana, a few blueberries per day via lipid energy model physiology, along with our understanding of hormones. The lipid energy model kicks the dietary cholesterol's butt in terms of what levers in this context are contributing to serum cholesterol. And it made for an amazing thumbnail. And I saved egg cartons and put them on my bed, so the hook is just gorgeous. So you have to excuse me for enjoying playing with a little bit of a legit bait on this one. We'll see how it performs.
We'll see if Jesus can match you on that thumbnail.
Well, we're gonna put a video in the description as well. So go ahead and check Nick's channel. He's really crushing it on YouTube, and we're very happy.
Second that.
I will say though, it was a hook for. So if you watch the video, you'll notice a theme twist at the end, where I make commentary on dialogue on social media and sometimes why it's so hard to have nuanced discussions. Use 720 eggs as a case study of itself, a little poking fun of itself, but you'll get what I mean if you watch the video. I had a purpose beyond just me eating lots of eggs.
Well,
Yeah,
mine
definitely.
is a stunt as well, but it's a stunt with a purpose.
Yeah, I actually opened this, like, why did I do this? And you might think I'm crazy. I'm like, well, I am crazy, but I'm crazy with a purpose. Same with Oreo versus statin. Sometimes, given the practicalities of the world we live in now, you need PR stunts in order to force discussions that you want to happen, provided you feel that you actually have something to contribute to a discussion and that the provocation that is the packaging can result in fruitful dialogue and learning, then I think it's fair game.
Yep.
Jesus, anything before we go?
No, thank you so much. If you're watching the show and you stay this long, we really appreciate it. We know this was a long discussion, but really, I mean, it's worth it. And you won't find stuff like this easily in other places. Have all these three gentlemen sharing their findings, and this is just, as you said, the first step of many into understanding the intricacies of LDL cholesterol and cardiovascular risk.
Thank you.